Doreen, Moraa, good morning.
Good morning to you.
How are you?
I am very fine.
Thank you very much for joining us today and for this conversation that we're about to have. I'll have Janet introduce you properly.
Well, no, I mean, I know we can also throw it back to introduce herself, but Doreen has been very vocal on matters HIV/AIDS. Undetectable Queen, is that the nickname you give yourself?
That is it.
That is it. I think it's important, even as we go into how this stop work order has not only affected organizations, but Eric's point, how it's also affected individuals. And before we go into that, is just to give us a little bit of a highlight on what you like to call yourself, and more than that, what it means to be an undetectable queen.
Okay, so hi again. My name is Doreen. I am a young woman living with HIV. I have lived with HIV my whole life. And basically, I call myself the undetectable queen because I have achieved undetectable levels of the HIV virus. So my viral load is low, which means I cannot transmit to any other person. So that's what we call undetectable equals to untransmittable. And you reach undetectability by being on ARVs faithfully. Yeah.
Wait, so you even now when you have low viral load and it's actually undetectable, you must continue taking ARVs?
Yes, the ARVs are the key to you being undetectable.
I see.
Yeah.
What happens if you default?
We don't call it default anymore. We call it treatment interruption. So if you interrupt your treatment, the viral load comes back up. Sometimes people will get what we call treatment resistance. So maybe the medication you're taking at that time will stop working, or you now obviously are able to infect another person. For mothers who are also breastfeeding, they end up infecting children. And basically, it creates chaos when you stop taking treatment. Yeah.
You're a champion on this, so therefore, you must know many in the community and a wide network. Can we say we have many people who are undetectable kings and queens in this country?
Yes, we do.
Do you know the number, like in a network? Are you in a network that can say, I know X number of people?
Well, I cannot put the number in numbers.
Okay.
But there are, UNAIDS has this goal of 95, 95, 95. So the first 95 is 95% of the population to know their HIV status. The second 95 is 95% of the population to be on treatment. And the third 95 is 95% of the population to be virally suppressed or undetectable. So Kenya has 1.4 million people living with HIV. At least 1.3 million of them are on treatment. So when it comes to the 95, 95, 95 goals, we are cruising nicely, well up until 2025, but we have been cruising nicely so far. Yeah,
We've been doing very well so far.
Yes.
Now, this is a conversation that we've had this many times here, that our HIV programs have been heavily funded by external donors.
Yes.
USAID, Global Fund, and others. Is this true?
100% true.
Okay. Now, the USAID has frozen funds into very many programs. Has this impacted the HIV/AIDS program in Kenya, the HIV and malaria and TB program in Kenya?
Yes, it has. It has because they were not just supporting treatment. You see, there is the treatment aspect of it, and there is the program aspect of it. So they were supporting both treatment and programs. Personally, I was going to a clinic that was supported by PEPFAR through a local organization. So currently, I do not know if that clinic is open.
Okay.
Because my next clinic appointment is in June. So I do not know if when I go there in June, they're going to send me to either the county hospital or the sub-county hospital. But for now, most of the clinics that were being supported by USAID were closed indefinitely. That means that the people who were going there were being redirected to sub-county facilities or county facilities to get their medication from there. So that is the treatment aspect. So we also, in treatment, we also have the testing. So there was a waiver that was issued. The waiver was like, you can continue giving life-saving medication to people. But now there are also tests that we do. So those tests have been halted for the time being, even right now. The medication, some people are getting, because I get like 6 months. Some people have been getting now 3 months or a month, depending with where their facility is at. So, and they're not getting tested. So we're not doing the viral load at the moment. Children born to HIV positive mothers are not being tested. I don't know about the possibility of testing for HIV unless you're buying a self-test kit. But from the hospital point of view, it's a gray area. So there's been a disturbance, or rather some form of disruption there. So now when you come to the programs, there's so many programs in the HIV response. There are programs for eliminating mother-to-child transmission. Kenya has actually a commitment to ending AIDS in children by 2027. So I don't...
How does this all go with all of this?
Exactly.
That's happening?
Yes. So that's a very great commitment. But you see, we cannot end AIDS in children without medication, without prophylaxis, without tests. We can't do any of that. Then there is now programs for key populations. So those ones have been very much affected because of the policies, the US, how they changed things. It kind of trickled down to many, not just Kenya, but many African countries as well. So that is now the reality.
Where we're at.
Yes.
The big question is, when people are referred to government clinics now and they're told that's where you're getting your medication from, do they have the capacity, to the best of your knowledge, to provide ARVs, to test everything in between, prophylaxis?
ARVs, yes, not with the broader regimens, with the broader dosages as we've been given, because some people, Kenya had started practicing something called differentiated service delivery, where you don't necessarily need to go to the clinic. You can your medication can be shipped to you, you can pick it from a local pharmacy, you can be given for 6 months because you're a stable patient. But now you can't, because there is that disruption. That is another program that has been disrupted. So then when you look at going to the county or sub-county hospitals, that has been an issue. Because remember that, especially now, let me use myself as an example, because I've been going to a program-based facility. The doctors there, they're used to dealing with people living with HIV. The stigma is way lesser. The county hospital is not exactly the same. I know people in the hospitals are healthcare workers, but not all of them understand the magnitude of stigma and things like that. So I think the second day after the stop work order was issued, there's somebody who reached out to me on Facebook, and she was like, so where do I go for my treatment? So I told her, go to the nearest county or sub-county hospital. She told me, my friends work there, I can't go there. So that means we're losing people in care because of stigma. Because they are known, you see, especially in most of the rural areas, people know each other. So I'm not showing up to the hospital to collect ARVs from the general pharmacy, and my cousin works there. So there is that.
Take us through. So you said from June is when you'll know whether the clinic that is open or not. Yes. So take us through a scenario for somebody like yourself, almost also based on what Mariam asked. Say you go there and it's closed, and will you, as Doreen, say, okay, I'm going to go to the nearest county government hospital. I go there. Number one, I'm aware that either I'll face stigma or there might not be the treatment etc. I'm looking for. Therefore, my other options would be what?
There are no other options, Janet, unfortunately. The options are either those, or you go to a private facility that requires payment. So for the county and sub-county hospitals, so for example, my clinic is inside Kenyatta. So that means we are probably being moved to the main hospital. So if we're being moved to the main hospital, the queues, the healthcare professionals, you know how the public hospitals are. So that is our new reality. Kenya had started something called integration of services, where we, as people living with HIV, will meet with everybody now at outpatient level, pick our medication from there, get treated from there. But now that had not, it was a conversation. The system had not yet been set up on how that was going to look like. But that is now something they're now accelerating. So in case I go back in June, probably I'll end up at the outpatient.
Yes. So, okay, you end up at the outpatient, but then there's still the question of how do you get the care that is required, like you've said, when all of this is happening, not just from the getting the medication, just from the care and everything, from a cost perspective. Give me a rough figure of if I'm going out of pocket for ARVs in a month, how much am I spending?
I honestly don't know, because we've been getting medication for free. We've been getting everything for free.
Right.
So the tests, the treatment, unless now it's like something else, like another health condition, so that's now when you're guided on where to go to.
Right.
But everything else has been free. So if now we are going to go into buying,
You wouldn't even know how much or
we
where to
do not know how much you're going to spend on that.
You know, the U.S. government, either through the Global Fund and PEPFAR, USAID, and all that funding, they've been supporting the Kenya government in this HIV program. So medication comes in through KEMSA, and then they also support the programs outside of the government circles. But the government is also aware that here we are sort of complementing one another. The government facility versus this other, NGO facility that is complementing the work of government, just to extend the reach. So if the source for government and NGO is cut, to me it sounds like even at government, they also are affected with all these things, supply and all. But even then beyond that, it also tells me that the kind of training that the practitioners at the NGO facilities were getting was the same kind of training and programming that those in the public health facilities should have been getting.
Yes.
But I hear you talking about stigma more than once. Are you saying that the training in the public facilities was insufficient? That you've heard people complaining that if they compare, the public health facilities are encouraging stigma? Is that what I'm hearing you say?
Yes.
How so?
So healthcare workers are human beings.
Yeah.
And they have their own personal beliefs. When it comes to HIV, when it comes to the populations of people living and affected with HIV. That means they're going to see us from a different perspective. We've seen healthcare workers come online and say, people are sick out here, take your treatment, like all that fear-based type of education that they're getting. So for healthcare workers that have specifically been working in these facilities, they're trained on how to reduce stigma, to ensure that people living with HIV remain on care, because stigma basically makes us lose people in care. Remain on care, follow up with mothers living with HIV to reduce mother-to-child transmission of HIV, know where these particular people living with HIV live, because at some point, if you get lost in care, they will come and find you at home. So it's been like that is how they were trained. But that does not apply to the whole general population of healthcare workers. So I think in the last 6-7 weeks, a lot of stigma has come out, especially from the Kenyan perspective. There has been so much stigma. There have been people like we see, because HIV is related a lot to sexual transmission. So we've seen people say you should have abstained, you should not have had many sexual partners, without acknowledging the fact that there are children born with HIV and there are people who get HIV through injecting drugs. So it's like a whole
You've seen it how? You've seen it, people reporting this in groups, saying that they're going to public health facilities and this is the kind of response that they're getting or reception they're getting?
Well, the first interaction I saw was on social media, where somebody said, she is a healthcare worker, and she said that she can't wait to see how we are going to start falling on the streets. Because now medication has gone away. So that was the very first one. They were like, oh, this year we're going to bury so many people. And I was like, that coming from a healthcare worker is very problematic. Because now it means that the people who will find you at the healthcare facility, you're not going to look at them as human beings that require service. You are looking at them as people who are at one point going to die. And I feel like we've worked so hard over the years to say HIV is not a death sentence, but we've reached 2025 and made it a death sentence all over again.
Wow.
Yeah.
It's interesting. It's almost like the stop work order reveals, even more than capacity, it reveals underlying stigma that has existed.
Yeah.
And even if I'm to step a little bit outside of HIV, then come back, even matters like menstrual health, etc., you'll notice such a difference in education depending on which sector, whether it's government. I mean, up until not too long ago, there's a lot of parliamentarians, let me put it that way, who didn't believe that people still use mattresses and cotton wool. They'd be like, you're lying. Say, but you just have to step outside your door to know the reality. And you can assume that because we're in 2025, people are a lot more aware. But it keeps revealing either an ignorance that is returning or that has always been there. And I think that's even more troubling because, to Doreen's point, if your perception is already you're a sinner, everything else follows.
You know why I'm asking this question and being so persistent about it? Is because I'm looking back at this has been an over 20-year strategy.
Yes.
And the 95 is global, but also has been adopted by the government of Kenya. And we have institutions in government. We have KEMRI, which does a lot of research and also runs some programs. We've got NASCOP. We've got what used to be called the HIV Control Council, which is now National Syndromic Diseases Control Council. But they've been working, they're the ones who've been coming up with the messaging and the training and the licensing even of all facilities, whether private and public. And that's why I'm sitting back and wondering, so how is it that you're saying that those that have been working in the directly funded NGO sector have been better trained and their attitudes have changed, but those in the public sector, they have not been reached to by all these organizations that have been the ones that are running the HIV
they've been hiding behind. They've been hiding. It's okay. You can present that you understand.
Yes.
You can present and be like, yeah, because that's where everyone is saying. But deep inside, to her point, I like how she said people are human. Perceptions still exist.
But this human being is the same Kenyan human being of Luo tribe or Kikuyu tribe or Taita tribe as the one working in an NGO.
Yes.
So I want you to show me, is it the training in the NGO that was being conducted differently by the NGO? Or because I'm coming in from the point of it's a government program.
Yes.
The HIV program in Kenya was not a USAID program. It was government program supported by USAID.
You can pass an exam.
But do you understand?
But have you understood what was necessary?
It's the same examiner. You're telling me the teacher is same. Okay?
Yes.
Examiner is same. But because you live here and you go to Lavington, you are different than the one who has crossed over into Gatina.
Let me give another example. The CRA question is, you're walking and you find 50 bob on the ground. What's the right thing to do? Everybody knows which answer to pick.
Yes.
But
do you believe?
And everybody will pick that.
So
but when they come across the 50 bob on the ground,
before we get down to Doreen.
I agree. But what is the difference between what is it that is making the one who is going into NGO to be more receptive of this than the one who's going to...
I think internalized stigma, but I want to bring it back to Doreen. Again, I'll go back to 2019 when there was this really heartbreaking story. The same teachers who have been trained, again, to give information on menstrual health was the same teacher who then shamed a girl. She's also been trained. It's not that she doesn't know, but that internalized perception, whether it comes down to how culture talks about our bodies or HIV or whatever, begins to then play out because she shamed this girl. But I want to throw it back to Doreen to, she's had us debating amongst ourselves.
Even you're involved in this debate. I'm just pushing back on this thing of that NGOs are better.
No, we didn't say they're better.
NGOs are not better. I'm just saying healthcare professionals are human beings.
Yes.
When they go, when they're being trained by these particular organizations, there is funding, there is a training for healthcare providers. This is how you treat people living with HIV. This is how you follow them up. This is how you use people-centered language on them. Makes sense. Everybody is on the same page. But now when the rubber meets the road, that is where the problem comes in. The internalized stigma. And you know, with HIV, over the years, I think there's a generation that saw people die of AIDS. There is a generation that has never seen people die of AIDS. So bringing those two generations together to make it look like at the end of the day, these are human beings. They're not contagious, they're not sick, they're not going to infect you by touching you. It takes a little bit of time, not a little bit, it takes time because of how HIV was presented. Remember, way back in the 90s and early 2000s, the messaging was AIDS kills.
Yeah.
Some people have that messaging in their heads to date. Because even
whether in private or public.
Whether in private or public.
Yes.
So because the same people will have people living with HIV in their own homes, but they will come to social media and then they'll tell me, Trump is coming for you. But they have left their own people living with HIV right inside their house because they don't know about that person, but they know about Doreen. So it's the personalized and internalized stigma that kind of jumped out once the stop work order came, and then now everybody thought it's a free fall. So yeah.
Correlation, causation.
Yes.
We have a caller on the line.
Yeah, we have a caller, Patrick Adere from Kitale. Patrick, do you have a question or contribution? What would you like to ask Doreen?
Morning, guys.
Morning.
I'm Kadere from Kitale.
Yep.
Mimi ningependa kusema my comment kuhusu huo daktari wetu hapo amesema mambo ya ukweli. Unajua USA imefanya Afrika, especially Kenya, tutakuwa na shida kubwa sana. Because hii madawa za HIV zilikuwa zimesaidia watu, ikawa huwezi jua mtu mwenye ameathirika, ilikuwa watu wanaishi. Lakini vile imekataa kufanya hiyo nini, watu wataangamia. It's the end of this year, utaona watu wengi sana. Sasa itakuwa ni death sentence. Because ilikuwa inasaidia, huwezi jua mtu. Lakini saa hii itakuwa juu sana, vifo vitakuwa juu zaidi ya sana. Because vijana hata Kenya, mtaa yangu huku walikuwa wanasema ati ukimwi si kija, ukimwi ni kama malaria. So walikuwa pia wanachukua tu ni kitu ya mzaa. Lakini kwa saa hii ukweli ni kwamba huwezi saizi katia msichana ama fanya na mtu saizi bila kujua yadhi yake. Inabidi sasa saa hii watu wamejichunga sana. Amerika imechanua, imeleta hiyo shida, lakini pia imesaidia watu. Sasa saa hii wamekuwa na tahadhari sana. Alafu pia ningesema jambo la mwisho kuhusu stigma. Stigma itakuwa juu sana. Kwa hapo nyuma ukijua mtu mwenye mgonjwa ni nani, lakini sasa utaona mtu amekonda, unaanza kusema ule ujichunge. Sasa stigmatization itakuwa juu pia sana. Hapo ndio shida iko. So daktari muangalia hapo ile mtafunza wananchi. Watu wanachukulia watu wenye wameathirika kuwa tena.
Sawa, asante sana Patrick.
Okay.
Let's, that's, I think, an example of the messaging and the perceptions that are already beginning to come out. How do you respond to that?
So anyway, so you see,
you can collect for
so
1 second.
First, as you recollect yourself, Doreen is not a medic.
Yes.
Right? Doreen Moraa is just an advocate. She has lived with HIV all her life, and she is the undetectable queen because she has been very consistent with taking her ARVs. She has very low viral load, undetectable. So she's here as somebody who has lived the life, not as somebody who is an expert doctor on these matters. Higher. Now, the messaging and the perception, as we're hearing,
unfortunately, that is the perception right now of saying that if you're going to be thin, you're HIV positive and all that. But the right now is we have medication. It might not be as long term as we want it to be, but right now there is medication, which means nobody is dying for now. So I would have wanted us to, over the years, change the perception around HIV. But we have not yet done that yet. We are yet to, actually I think this year is the 1 year I am seeing so much HIV conversations than I have seen in such a very long time. Because now we are, I think when medication came, because there was a time that there was no treatment. So when medication came, everybody just kind of was like, as long as people are on treatment, everything moves forward. But you see, these perceptions never went away. These perceptions are still there. And when we talk about people living with HIV, we tend to forget the HIV negative population that consumes PrEP and PEP. So in as much as the caller is saying...
Just let us know for people who don't know PrEP and PEP. Yeah.
So PEP is post-exposure prophylaxis. It's used to prevent HIV after a sexual encounter within the first 72 hours, and it's a 28-day dose. PrEP, on the other hand, is pre-exposure prophylaxis, so taken before a sexual encounter for 7 days, and then you continue for as long as you're on it. So some people who are in discordant relationship, or rather a relationship where one person is positive, the other one is negative, they usually use them. People with more than one sexual partner are always advised to use them as well. So that basically applies to the HIV negative population. And in 2025 now we are seeing we are moving a little bit away from the oral medication to now injectables on the PrEP side. So when you hear perceptions such as you cannot go after a HIV positive person because they're going to infect you, but then people who don't have HIV, we tend to forget them in the conversation because they are the larger population. And basically they're the ones that we need to prevent from getting HIV. So PrEP, as of now, PrEP is currently being defunded in a very heavy way. I do not know why, but most of the funding is going away when we are seeing now better inventions of PrEP. So there is that. So everybody needs to get worried.
Is this in Kenya or globally that it's being defunded? Globally it's being defunded?
Yes.
Just as we are making progress?
Yes.
Okay, that's very weird, and I want to interrogate kidogo, but we have a caller from Machakos who also wants to ask a question.
Rose.
Yes.
Habari ya leo?
Mzuri sana.
Asante sana kwa kupiga simu. Uko na swali ama ungependa kuchangia mjadala huu?
Nilikuwa naulizia. Halo?
Tunakusikia, endelea.
Ongeza sauti kidogo.
Nilikuwa naulizia. Nimeolewa. Halo?
Yes.
Endelea.
Nimeolewa. Na bwana wangu ako na tabia ya hapa na pale. Halo?
Tunakusikia, endelea.
Sasa sijui nitasaidika aje sababu tumetengana kidogo kiasi.
Mmetengana, una suspect?
Tumetengana kama miezi, tuseme miezi 5 hivi.
Miezi 5. Na alikuwa na tabia ya kwa hapa na pale? Sawa.
Na nikimwambia tuende tupimwe anakataa.
Wewe umepimwa? Wewe umepimwa? Okay.
Sawa.
Lakini mmetengana. Asante. Asante Rose.
Wacha tuulize Doreen hapa what to do in a situation kama hiyo. Katu kwa line. Aya.
So Rose, kwa situation kama hiyo unafaa kuwa una meza tembe zinaitwa PrEP. Wewe unaziendea hospitali na ni free. Right now I don't know whether to say things are free or not. Zimekuwa ni unapewa bure, unaingia hospitali, unawaambia haujui hali ya bwanako, na pia unawaambia kwamba bwanako ana mienendo ambayo haukubaliani nayo. Kwa hivyo kukinga kutokana na kupata virusi vya ukimwi, unameza hizo tembe za PrEP. So unazimeza for as long as uko kwa mahusiano na yeye, that is kama mtarudiana. Kama mtarudiana basi ndio hivyo.
Sawa, asante sana Rose. In your network, I mean, I know people will ask you questions as if you are the expert, right? But this is information that is shared in networks. Do you know whether this is information that then is shared in communities? Because there's so many concerns such as this. I'm suspecting that my partner may be unfaithful. So what do I do? Or I'm actually HIV positive. I'm living with HIV, but I'd like to get into relations. And how do I disclose this to, my potential partners? How do I deal with this? Do you have such conversations in groups? You're an advocate, so I'm sure. Unatembenga kwa mitaa.
Well, technically sitembengi kwa mitaa, but because I use my social media platforms for advocacy, so I usually teach people on different HIV topics. on different days, and I do get such kind of questions from the discordancy perspective, where my partner is positive, I am negative. What do I do? How do I disclose? And you see now the current situations that we are living in are not even like situations that will encourage somebody to disclose their status, because the fear has kind of gone high. So in as much as disclosure is very much important for people living with HIV, the stigma is still there. We have to face that reality. And I think that it's time we also have to have conversations around HIV that we kind of dismantle the stigma, because we have not yet reached that point. We have just assumed as long as people are taking treatment, we don't know who they are, even though they are our family members, we're good. But we're not good, because now here we are with people struggling to say that they're HIV positive, with people struggling to know their diagnoses, with the people saying as long as kama hakuna dawa hakuna jamii nipimwe. So there's all that. We were doing so well with the U=U, keeping people on treatment. So you encourage somebody that as long as you're taking treatment, you cannot transmit to another person. So now most of the people are worried, am I going to lose my undetectable status because of the way treatment is currently very unpredictable? So there are those kind of concerns, which are very valid actually. Yeah.
So now for discordant couples who may be listening and watching us, how do they make sure that they stay discordant or they continue to be safe and healthy even in the midst of this USAID freeze? So sorry, who from Kitengela? Bena Benga. So let's get another call and then we can answer that one. Bena, what's your question? Ben Abenga. Kutoka Kitengela. Swali yako tafadhali. Hi.
Hello.
Tunakusikia?
Hello, morning.
Morning.
Hello, Heli Kadelet and the team.
Okay, I think we're having a problem with the Ben's line.
I'm calling from Kitengela.
Go ahead.
I don't have a question other than maybe kumpongeza mwanadada kazi ambayo anaifanya. I would like to say kudos to her. What she's doing, she's doing an amazing job. Yeah, that's why I'm a biggest fan. No one amfuata kwa social media platforms zake. What she's doing amazing work.
Fantastic.
Ben, if I may ask you, are you there, Ben? He's gone.
He just wanted
wanted
to appreciate Doreen.
Just flowers and
and she does do it. That's how I
wanted to ask him about the perception from where he sits on the things that we're talking about. And I mean, has there been a change in perception? How do we deal with stigma in the society? This is something that has been fought for very long.
Decades.
Remember,
40 years.
even the government's own communication messaging then was Kimwi Naua, HIV kills, right? And then they realized, oh my goodness, what we have done here. And they completely changed and said, now you can live with it. And they completely dismantled that whole conversation. Having HIV, having any other disease, just go to hospital, get your treatment, follow the treatment routine that has been prescribed for you, and you will be okay. You will live a normal life. This has been the conversation. We have younger generations, like you're saying, who did not live in the 80s into the early 90s and mid-90s, where people were dying in great numbers. And that was a messaging. A majority of the population is actually people who are below 30. So where did they get this messaging from? Where did they get this stigma from? Where has it...
It's like a resurgence of stigma.
Yeah, where is it coming from? If we don't have stigma today about malaria, and malaria is a bigger killer in Kenya, right? So why do we have stigma about HIV? Is it the sex factor?
It's the sex factor. One, I think as Kenya, we like putting ourselves as a moral country. So which means sex is immorality, which means if you're immoral, then you get HIV. I think the first place was school. Because even before I knew that I'm HIV positive, was taught about HIV in school. And our teacher was like, stay away from sex, stay away from men, stay away from women, you are going to get HIV and you're going to die. So that was basically the messaging. So we grew up with that of stay away, stay away. And then now when finally,
it was revealed to you.
Yes. So now I'm like, okay, but I was born with HIV. That messaging does not relate to me. So because the majority of people get HIV through sex, we kind of forgot that there is there are children who are born with HIV who have now grown up and they're adults. And they did not participate in any sexual related activities. So because of that, and because of the whole morality aspect, the religion aspect, the culture aspect, we have kind of still hold that, that no, as long as this person is HIV positive, they might infect me, they are going to die, and all those kinds of things. There are some of the people that you meet and they're very much informed about HIV and they know what happens. There's some of the people who still kind of hold the stigma. So.
Yeah. Mariam had a question. Just before we get to it, why was it important for you to tell your story?
It was important for me to tell my story because we were not unpacking the stories of people living with HIV. Like at one point, we just kept quiet as a country. Medication came and everybody was like, oh, finally, let's go back to normal. So that going back to normal was not normal. Because people still were getting new HIV infections. Children were still being born with HIV. And the HIV exposure was still at a high rate, but we were not talking about it at all. And then now came in the whole aspect of being prayed for to get cured for HIV, drinking mitishamba. I am a Babu Eloliondo alumni, drank the cup, and we still didn't get cured. So because of all of those things, I looked at the conversations we were having were fear-based, that you're going to die. But then I have lived with HIV my whole life and I have not yet died. So I had to show people that there is a life beyond our diagnosis, that people living with HIV are not somewhere, like they're not aliens, they're human beings. They're your brothers, your fathers, your mothers. They live with you inside your house. They might not have told you that they're HIV positive, but they live with you. They take medication right under your house.
We've seen somewhat steady increase in new HIV infections, especially amongst young people, young women to be specific, and then in married couples again, which is another, you wouldn't expect it, but here we are. If today we were to do, because I think early 2000s, Nime Chill, Mpango Kando, it stuck, it did something.
Yes.
What would a version of that what would messaging look like right now that you think would be effective?
I would like to see more voices of people living with HIV, to show people that the H in HIV actually stands for human beings. I would also like to see information-based teaching from prevention on the different prevention messages methods that we have. And now there is something that was launched in 2023 called the Choice Manifesto that creates a choice of HIV prevention methods for adolescent girls and young women. So we have condoms in there, both the female and the male condoms. We have PrEP in there, we have PEP in there, we have U equals U because it's a prevention method from the positive side. So it's this choice.
I like
which one are you choosing
as
from?
opposed to scaring people.
Yes.
I remember very distinctly being in primary school and being shown very graphic images of people with STIs. And that was the method. It was like, you see, this will
Nobody has forgotten those videos.
Right? Exactly.
Like, I don't think
burned in people's memory. But it doesn't achieve what it's meant to, which is now where Doreen comes in.
Because I was, the other day when I was coming back from San Francisco, at the airport they have an AIDS kilt. So it's written like, let's love each other, HIV is not a death sentence, like all those things. And it is like, it literally inside the airport. I even took a picture of it and I was like, I wish...
Which airport?
The San Francisco International Airport. I wish this was how we messaged HIV and telling people that it's not a death sentence, that the people living with HIV, they're not guilty, because sometimes when I say I was born with HIV, I'm told, oh, you were innocent. So the other person is guilty. So the other person is guilty of a particular offense. So trying to reshape the messaging, because right now we are moving into places where now we have U equals U. Make the U equals U message accessible to everybody. That it's not a 50-50 method, that as long as Doreen is undetectable, she cannot transmit HIV to another person. And make it believable, not how we message things. So
how we message things.
Doreen, what is U equals U?
Undetectable equals to untransmittable.
Okay.
Yes.
I just wanted you to repeat that.
I want to ask something because I like how you said, when Mariam said, how do we shift messaging in today? You said, have more people tell their stories. Yeah. But right now, people are scared to tell their stories. Yeah. How do you speak to that person who has, they say a story shared within you, kind of, number one, it kills the shame and it almost liberates, right? Yeah. But how do we do that? Somebody listening saying, man, I really wish I could share my story. I feel like I'm convicted to do so. How do they break past that fear, that shame, to say, you know what, I think I'm ready? And is there support for people like that? Maybe they fear that I don't have a community that will cushion me with whatever comes back at me.
So we do have the National Empowerment Network of People Living with HIV in Kenya, NEFAC. It's based on so many groups or communities of people living with HIV in all our diversities. So it's more of a safe space to us. So you can tell your story, you can open up, you can seek support and things like that. I have also had people who've come to me and told me, I would want to tell my story. And I'm like, yeah, you can go ahead and tell your story. But before you tell your story, you have to ensure that you have accepted your HIV status. Because at the end of the day, for you to be able to change somebody else's perspective on HIV, you must have changed your own perspective about HIV. So accept yourself first, like fully 100%. Because when you will log into social media and you will see somebody has said a very mean thing towards you and you're like, how did we get here? So because of that, you have to accept the personal beliefs of other people and try shift them. So you must acknowledge and accept your own story. And why I insist on lived experiences is I think there's a time I saw on Twitter somebody asked how the Western countries managed to reduce stigma. It's because they talked about it a lot. They talked about it and it was not a shameful conversation. But when you talk about HIV now in 2025, in Kenya you're told munarembesha ukimwi. So, and there is nothing, it's not a kurembesha thing, it's us living our truth, living our story. So, more people really need to open up about their diagnosis. Yeah.
Can I ask you a personal question, Doreen? And this is whether you are in a relationship.
Okay.
Are you?
No, I'm not.
Because there are then people who ask themselves the question, if I know that my potential partner is HIV positive, and I've gone and tested and found that I'm not, does this mean that I walk away? Talk about that.
So I'll start from a very lived experience point of view.
Okay.
My parents were a discordant couple. That means my mom is still HIV positive, my dad was HIV negative. So when they found out about their diagnosis was when I was also officially diagnosed. And my dad did not walk away. And a lot of people have asked me that was back in the 90s, how did he not walk away? Well, I do not know, and I never got to ask him that question. But he did not walk away. Discordant couples work. There are very many discordant couples who are working, and everybody maintains their own HIV diagnosis. What needs to be done is the prevention, because herein is where now condoms come in, if the couple prefers that. PrEP comes in if the PrEP is pre-exposure prophylaxis, if the couple prefers that. And as I said, that now the PrEP is moving from the orals to the injectable. So as we have been seeing that people living with HIV, people who are HIV negative keep saying, I cannot keep taking pills for a condition I don't have. But you see, if you are injected by a prevention method, then you're good. Then U equals U, the undetectable equals untransmittable also comes in. Because these are couples that have been able to give birth to HIV negative children. Thanks to what is happening now, we now have prophylaxis for babies, we have ARVs for mothers. So it basically works out to be in a discordant relationship. But all this comes from a point of communication as well as information. If you do not communicate with your partner, because there are people in relationships and marriages with two different HIV diagnoses, and none of them know the other's diagnosis.
No one even knows that the other.
No one knows the other. So, for example, I think last year World AIDS Day was focusing on men in Kenya, because most men wait for their wives to get pregnant, get tested. So if the wife does not come home and say they're HIV positive, then the man assumes that he's also HIV negative.
8 years ago, I was contracted by NASCOP and Global Fund to do just a documentary targeting teachers, because they were conducting training for teachers, especially in high school, on the issue of HIV and those children born with HIV who are in their school. So I went and spoke to adolescents who were born with HIV. Many of them came to learn about their status at the, that age of 10 to 13. That's the point, right? And they're now trying to come to terms with this. I presume now those ones are now old. 13 plus 8? Okay. So they're getting into that point of relationship. Right? So when you have lived with HIV all your life, you have gone through your teenage years and survived it. Now you're getting into this other phase of getting into relationships. What is the advice? You're meeting somebody. Do you go on and say, hi, I'm Jackie, I'm HIV positive? I mean, how do you break it down?
Well, that is where parents come in at first, because I was also told about my diagnosis when I was 13. And most teenagers are told at that age. I usually advise parents to start disclosure early. That way, when this child grows up, they don't fear disclosure to their partners, because so many young people born with HIV struggle in relationships. They are better not disclosing to their partner than disclosing and being left. But that is not the story. It is, that thing kind of does something to your psychological health. So that is how we end up losing these children in care. We end up seeing them proceed from first-line treatment, which is the primary treatment we start on, to second line or even third line. Not because this person was struggling to take their medication. The medication is not the issue. It's the fact that they're struggling to understand this diagnosis and navigate.
They're yet to come to terms.
Yes.
So how early would you advocate for disclosure? Parent disclose to your child.
When they start asking where they're taking treatment.
Because they start early.
Yes.
Because they're
they
taking
always
treatments
ask
on a daily, and they're
they always ask, kwa nini ninakunywa hizi dawa? The parents just always lie. So I feel that will be a learning moment for the parent as well, to disclose, or rather not just to disclose, but also to start the learning process of, do you know about HIV? Because most of the times it's been mentioned in school. So then navigate from that point. If you can't do it, then get a healthcare provider to do it.
Has the stop work order affected things like access to counseling, access to, is that also part of where the nervousness is coming in?
Yes. It has affected that so much, because we have counselors in the facility. We also have mentor mothers who mentor mothers who are HIV positive, who have given birth to babies who are HIV negative. We also have peer counselors now who some of them go the extra mile to these people's houses. So all of those people lost their jobs. So some of the people, like especially for mentor mothers, they will go pick prophylaxis and ARVs from hospitals to give to the mothers. So now the mother has to do the job of going to the hospital, which now kind of brings that nervousness of, I don't want this. Gosh,
it's such a disruption, and it keeps unfolding. I like, I mean, the information you've shared is so helpful. Hopefully once June comes around or post that, you can also just keep us updated. I think our role as well here is to just make sure people have access to information, how they can access, is it medication or counseling? Because by then I think we'll have more answers. But thank you for the work you're doing. I think, do we say bye to Doreen, then do the news fix, and then cross over to
We're doing everything
your world? We're doing everything
together.
together.